Good morning, Dr. Suzanne.
Good morning.
Thank you for joining me. I'm excited to talk all things women's heart health. Yes, welcome.
It's great to be here. We're talking about my favorite topic.
That's great. We're glad that it is your favorite topic because you're such a fantastic expert. And so, just off of the top, we hear a lot. I think it's pretty common discourse that women's heart disease manifests different than men, but I'm not sure women really understand what that means. So, how does heart disease present itself in women typically compared to men?
This whole conversation is so interesting because we have always thought of heart disease as a man's disease.
Mm-hmm.
That's been the story. And what we do realize is that is not the case. More women die of heart disease than all cancers combined. And in fact, they die of heart disease more than men. And part of the issue is that all the testing strategies and the way that women are looked at is the same way that men are looked at, and they just have different disease. The reality is when men get heart disease, it happens in one location in the artery. And a lot of our testing looks for normal versus abnormal
Mm-hmm.
arteries. And so when we do the test and men have disease in that one location, it's very, very easy to see.
Okay.
And we tend to have disease diffusely
Mm.
throughout the artery or in the small arteries called the microvasculature.
Okay.
Because of that, it's often misdiagnosed. It's often
Mm.
missed by our standard diagnostic strategies.
Mm. And what kind of symptoms should women sort of be aware of to say, oh, there might be something up here?
The typical symptoms we say in medical school is an elephant sitting on the chest. That's the typical
Mm-hmm.
male symptoms. And women, although chest pain is the most common, they also get shortness of breath just as often. So, shortness of breath, jaw pain, back pain, nausea, vomiting, even flu like symptoms, sleep disturbances could be a symptom of heart disease. But what I always tell women is go live your life.
Mm-hmm.
And all of a sudden, if the things that you do are harder than they used to be, walking upstairs, carrying packages down the block, and all of a sudden you're feeling short of breath or palpitations or you're getting pain, that's the time that you really have to think, is it my heart? Because if all of a sudden your normal activities are challenging, you've got to think about your heart.
Mm-hmm. Absolutely. I had a major scare. I almost died at an Ironman race and went to subsequently ended up, long story, but ended up in the hospital. And they were doing all of these diagnostic tests, couldn't figure it out as it relates to the heart, couldn't figure it out. And all of the information was coming at me so quickly. I was in a panic of, living or dying. Um, and so, and my point in that is, I had to keep advocating, and I knew people that were helping me to get the test. So, what would we say to women, like if they just know something's not right, and this is the current experience for women, typically, unless they have access to, a physician like yourself? What kind of advice do you have for women as it relates to advocating for themselves and through this process if something's up?
It's a three-step process. You've got to get educated, you've got to get empowered with information, and then you can advocate for yourself. But the truth is, this idea of medical gaslighting happens most often in the cardiovascular space
Oh.
because the symptoms are so different and it's so hard to diagnose. But if you know something is wrong, you get an answer.
Mhm.
Do not give up. You go to a different doctor, you sit in the emergency room and you say, I am not leaving. Something is wrong. And that self advocacy has to come from a place of you know your body better than anyone else, period,
Mhm.
end of story. And you're not going to defer to a medical system or a physician. You're going to defer to your intuition and to your own self knowledge, and you get the help that you need. Demand it, period.
Mhm.
If you can't do it, have a friend, spouse, I don't care who it is, somebody with you to speak up for you. Because sometimes when we don't feel well and we're sick, we're not always our best self advocates. So
Yeah.
that's what I recommend.
Absolutely. I think that's fantastic advice. And I like the point around a family or a friend. I absolutely wish I would have called on some people or
Yeah.
even requested them to slow down the information because they're so busy. They think their knowledge translation is great, but really there's a big gap between the world and the language that the doctors are using and the world and the language that we understand. So I think that's really great, Dr. Suzanne. I heard you speak a while ago, and you referenced a fantastic study about women being knowledgeable that heart health is important. But the percentage of women that actually thought it would happen to them, can you remind, because I think it's so important and I'm butchering it a little bit. So can you reshare that information? Because I think it's really important for women to hear.
I think this is the crux of the problem. This one little study, it was 1,000 women, and in this group, they were fairly educated. And the question was, how many women know that heart disease is her greatest health threat? 98% said, yep, we know it. Then they said, how many women think that heart disease is her own personal problem? 13% said it's my problem. It's like it's everyone else's problem, but it couldn't possibly be mine.
Mm-hmm.
And I think the reality around this is that women do not connect with their hearts as possibly being an issue. And I think it happens for multiple different reasons. We feel like we're doing the best we can. We feel like it can't be us. That's, a weakness.
Yeah.
And we're very strong and very capable and very competent and all of those things. But if we think about the heart in a really different way,
Mm-hmm.
it's not the exercise we did today or in the past year. That's great. It's not the diet that we just took on. It's
Yeah.
really much more than that.
Mm-hmm.
It's adverse outcomes of pregnancy. What happened when we were pregnant? Do we have a family history? Is there any inflammatory issues? When I start talking to women about inflammation and they're like, wait a second, I think I have that
Mm-hmm.
for multiple different reasons. I have to say, COVID changed the story. We
Right.
all have inflammation now from
Yeah.
COVID. We have to talk about our family history. We have to talk about our entire lives and everything that's gone into that. Did we have a time of depression, overwhelming stress? Did you go through a divorce? Because I'm pretty sure that was a stressful time. And so many of us have experienced that.
Yeah.
Your heart carries all of this. It is your life story
Mm-hmm.
that is in your heart. And so that disconnect, we need to shift because if we all believe that we are at risk for heart disease, then maybe every day we would live our lives a little differently, protecting our hearts, the same way we might say, I'm getting a mammogram every year, no matter what, because I don't want to have breast cancer. Well, I don't want anyone to stress me out because I don't want to get heart disease.
Yeah.
So it's just the same idea.
Yeah, I think that's really an important mindset. And I had a cardiologist friend who shared it in a frame as well, similar in terms of if you think of the moment sort of you're born and you go through puberty, like your arteries start to collect plaques. Like it's not, to your point, it's not something that, you can draw a line in the sand and say, oh, now I have heart disease because I didn't do this or I'm doing this. It's really something that's building over time. And so if you kind of have that mindset, it really changes things, I think.
There was a really kind of tragic study that looked at people less than 55 years old. And these were young people. I mean, like starting 18, 35, and there were autopsies done on this group. They had died from car accidents, things like that. So they were healthy, but had traumatic deaths. And in that autopsy, they found plaque building up in
Mm,
teenage years in the men and in the women at around 18,
yeah,
19. It was the beginning stages, very silent, very quiet.
right.
But what happens at that point moving
Mm,
forward?
absolutely.
I wrote a book
Absolutely.
years ago, and in that book I talk about how I was living on jelly beans and coffee through
Yeah.
medical school. Nobody told me I shouldn't be
Yeah.
doing. We all do what we
Yeah.
do. We
Yeah.
don't realize the impact.
Yeah. And I think I advocate a lot around this notion as women hit the perimenopause stage early, like get your baseline testing of your bone, of your muscle mass, of your heart, like get all the baseline information you can as you head into this hormone roller coaster. And I think it also pertains to get your baseline as it relates to spend some time in the quiet and think about like some of these lifestyle or stressors that you've had and almost kind of map them out because I think that's important knowledge. And I also think, as it relates to your family history, we think we know it, but spend some time with family members and actually kind of understand it a little bit more. I know, for myself, when I had this heart episode, I knew that we had a family history of heart disease. But then when I was talking to my father later to find out, he had extremely high blood pressure at the age of 40. And so, some of this information I think is really helpful to frame our decisions and our actions moving forward. Do you agree?
You're bringing up a really interesting point in the big picture, which is how do we define heart disease?
Mm,
And I think we have to really understand that by medical definition, heart disease means you've already had a heart attack, you've
okay.
already had a problem. We don't exactly think of risk factors like high blood pressure or high cholesterol, diabetes. These are major risk factors of heart disease. We don't think of them as being heart disease.
Right.
We think of them as being risk factors. But your father's history of having high blood pressure at the age of 40 is a very important thing to understand because if we think of that as heart disease, which we should,
Mm-hmm.
we're going to think of that one issue very differently in ourselves. Meaning, when we're 20 years old, we're going to make sure we don't have high blood pressure. We're going to get it checked again at 21. Why? Because your father had a really, really virulent kind of blood pressure that happened as a young man. So
Mm-hmm.
that means it could happen to us.
Yeah. And I think you're raising a really, really critical thing. And I'm definitely guilty of it as it relates to heart health. These terms and really actually understanding what they're using, what they mean, and using them correctly. Because, I haven't spent the time in the quiet to really understand the definitions between them. So, thank you for pointing that out for sure. And so, now heart disease, that's clear. Terms like cardiometabolic, um, cholesterol, stroke, like how can we decipher when we hear something like cardiometabolic? How does that differ from saying heart disease?
I think it should be called the same. And that's part of the problem that
Yeah.
we define it is so different. So cardiometabolic, it's really insulin resistance. It's how we're processing sugar. We really understand kidney function is incredibly important. And when we look at whether we have the metabolic syndrome, this cardiometabolic, which is an insulin resistance, whether or not we have high blood pressure or overt diabetes, all of and
Yeah.
let's go a little further actually.
Yeah.
If we have PTSD, if we're living with depression, if we're
Hmm.
living with anxiety,
Hmm.
all of these things in women are actually greater risk factors than they are in men. The way
Absolutely.
that the way that we feel has a greater impact on our hearts. So I believe we need to change how we diagnose heart disease and not wait till we're sick because the
Hmm.
true focus of heart disease, especially for women, because when we get heart disease, it actually we have worse outcomes than
Hmm.
men. We're more likely to die of a heart attack within the first year of having a first heart attack.
Hmm.
So why are we waiting for that moment?
Yeah.
I believe we have to focus on prevention. So if we change the definition and say any of these things, let's throw menopause in there
Yeah.
and say, you're in menopause, you might as well decide that you have heart disease because you know what?
Hmm.
70% of us will have heart disease during menopause.
Hmm.
So by changing the definition or the nuance around it, we can actually be in the position of preventing it so we don't get sick. And for me, that's the critical piece.
Well, and I do feel like it's exciting times in the medical world. I do see signs of a shift of the discourse from, you know, sick to prevention and health promotion. Are you seeing the same trends happening?
We are in a time where the cost of healthcare is so exorbitant, it's frightening.
Hmm.
Billion dollars are spent per year on cardiovascular disease. I mean,
Wow.
it's insane. So when we really address the need for prevention, the discourse in the medical system has to change.
Hmm.
We
Hmm.
have to look at things differently because we just simply can't afford it anymore.
Yeah. Yeah.
And now we're talking about things like value-based care, which means that physicians are being paid by how well their patients are doing.
Yeah.
And that includes treating the blood pressure to goal, the cholesterol to goal, getting patients to a good BMI, that getting their weight down so that cardiometabolic issue isn't a problem. And shifting to this preventive strategy is just good healthcare,
Yeah.
quite
Really
frankly.
is. It really
It
is.
shouldn't be a different conversation. It's the
Yeah.
way it should.
Yeah. It's fantastic. And so just going to the women in menopause, again, I think there's, you know, discourse changing around women's perspective as a hormone therapy. Still slow to come, but, you know, definite progress. How does, well, let me take a step back just in terms of how does the shifts in our hormones in perimenopause and then subsequently postmenopause, so, you know, peri being that roller coaster of low overshooting, and then subsequently post when it's low, what does that do to our cardio system? So, you know, the arteries, the heart itself.
It's really amazing that we're still questioning this whole dance, like this hormonal dance. I mean, this is something that we've known about for a really, really long time. And unfortunately, because there has not been enough research around exactly how we can fix these arteries during menopause. We're learning, but not quite there yet.
Yeah.
Women are suffering. But as we go through this menopausal dance, perimenopausal insanity, the arteries start becoming stiffer.
Hmm.
As estrogen goes down, arteries become stiffer. The lining of the artery, called the endothelium,
Hmm.
which is really what protects our arteries. It helps the arteries stay supple and dilate, and that is really the essence of arterial health. And with the reduction of estrogen, that lining, that endothelial surface gets stiff. Now, when the stiffness happens, this is when blood pressure goes up. We also know with a reduction of estrogen, there's an increase in cholesterol and an increase in LDL, the bad cholesterol, a
Right.
decrease in HDL, the more protective form of cholesterol. And we start developing belly fat. Now, what that does is actually cause a lot of this insulin resistance.
Hmm.
Um, we don't metabolize sugars as well. There's often weight gain because our metabolism changes. And so this reduction in estrogen hits every single part of our system that really sets us up for cardiovascular disease and plaque in the arteries.
And so now, if we could sort of talk about the notion of hormone therapy, I want to bucket it in a couple categories because I think it can be confusing with some of the information was kind of popular about a month ago, I would say. So the first point is around that notion of there was a pivotal study that showed if you started hormone therapy early, and those arteries stay a little bit more open, the endothelium's healthier, that it would, you know, sort of have a protective mechanism and plaques wouldn't form as much if you didn't, compared to if you didn't take it. If you started hormone therapy later, when you already had sort of more plaques that already pre-existed, and you get that the dilation, that there's a risk that some of those plaques might loosen and you'd have a thrombosis. Do I have that right? And can you give sort of an explanation for this?
So it's really interesting because you're bringing up a couple of issues that are so important in understanding hormone replacement. One is this timing
Yeah.
concept. And studies have shown that within the first 10 years of menopause, taking hormone replacement is actually beneficial. The Women's Health Initiative, which really just destroyed everything for us in terms of hormone replacement in menopause, looked at really a cohort of women that were older.
Mm-hmm.
And in this older cohort of women who took oral estrogen, there was an increase in heart disease and thrombosis, clotting, and everything that you're mentioning. But what it didn't answer was, does it matter if you take it orally versus transdermally versus intravaginally? And that question is incredibly important to understand. That
Okay.
was not part of the Women's Health Initiative because we know transdermal estrogen is much less toxic for us, decreases the risk of thrombosis, and actually, estrogen in itself is very good for the arteries, can help dilate the arteries, can help with this cardiometabolic issue. And so taking it transdermally is safer. But then you bring up another issue. What happens if you're on estrogen for the first 10 years? Can you continue it?
Mm-hmm.
Versus if you weren't on it at all and then you start it over the age of 65,
Yeah.
which is very different because you're living with low, low, low estrogens for a very long period of time.
Right.
And it happens now if you get it. And I'm not sure
Yeah.
in this second scenario if we have enough data to really
Mm-hmm.
understand.
Mm-hmm.
I will tell you that for my patients as a cardiologist, many of my patients do have some form of heart disease. They do have microvascular disease or some non-calcified plaque. And for these women, I don't say no hormone
Mm-hmm.
replacement. I say it has to be transdermal.
Mm-hmm.
Let's get it in that first 10 years.
Yeah.
We can continue it a little longer, but I don't recommend women who have not been on it, who do have heart disease, to start it greater than 10 years after.
Amazing. That was super clear. And so the second category is, and admittedly, I'm still confused because there was some conversation among physicians out there in social media about estrogen versus taking some of the common cardiac medications. Is this ringing a bell?
Yes, yes, yes. So there is a study, a meta-analysis that looked at hormone replacement, and it showed a reduction of cardiovascular disease as much as 30%. And
Okay.
one study was like 50%, which is enormous. And that was compared to statins.
Right.
And the thought was hormones are actually better than statins. That's actually not the case. Um, Treating heart disease and treating plaques in the arteries is not a one
Right.
mechanism way to do it because of all the risk factors that go into heart disease. And again, how are we defining heart disease? And what is the end point that we're looking for? So a lot of these studies are looking for this end point
Right.
of heart attack, heart failure, stroke. And then we look at what are we basing this mechanism on?
Mm-hmm.
And we don't have enough information for us to clearly say exactly that there is one thing we need to do to prevent heart disease. We need to prevent all of it. And we know that statins can reduce the risk of cardiovascular disease by 30%, the same that those studies showed around hormone replacement. Is it either or? I don't believe so. I believe you have to treat high cholesterol, you have to treat high blood pressure, and you have to treat menopause. And that whole, and the cardiometabolic. And
Right.
when you really look at what is the one thing, there isn't one thing. There are many things, but it's personalized, it's individualized, and the most critical way to be treated the right way is a personalized precision medical way of being treated. You as an individual need to be analyzed from your genetics, your metabolics, your functional, your physiologic, your inflammatory, your psychologic state.
Hmm.
That needs to be put together to really create a treatment strategy that works for you.
Mm. And, rounding it out, that HRT statins are not a panacea. Talk a little bit about, it's the common sense around lifestyle, but what's common sense is really hard to improve and change our behavior. So how important is sleep, diet, exercise, for our heart?
It's interesting to pivot because we've spent a lot of time, and I think a lot of people are focused on hormone replacement, statins. What do I do? What do I take? What do I ingest? Let me tell you, the most potent thing for all of us,
Hmm.
the best medication is exercise.
Hmm.
That is truly what is going to keep you vital, what's going to keep your blood pressure down, your weight down, your mood up, your bones healthier. I mean, exercise does everything that we need and is the cornerstone of all of this. Once we deal with how we exercise and how we eat and how we sleep and how we manage stress, then let's have the next conversation. But if you don't start with how you choose to live your life, nothing you take is
Yeah.
going to be enough
Yeah.
ever. Your
Yeah.
doses are going to go up. You're going to get side effects. You're going to go have off the medication. Like, we need medication to supplement our lives. But let's not talk about behavioral change, because when we talk about that, it's a setup for failure.
Hmm. Yeah, it's tough.
Let's yeah, let's talk about how much we're going to love ourselves.
Hmm.
Let's start there. Let's
Absolutely.
make a
Absolutely.
decision. Are you going to care about yourself enough to do what you need to do? How do you want to live your life? You could walk down the street. You could, I'm in New York. You could be on the subway. You could be in a museum. I don't care where you are. Look
Hmm.
around. Start
Hmm.
looking at people.
Hmm.
Look at their face. Think how old they are. Look at their feet. Are they swollen? See how they walk. You want to live vital? You want to get old? Just look at the picture. Here's
Hmm.
the interesting fact. In
Hmm.
some ways, you get to choose.
Yeah.
You actually get to choose.
Yeah.
Here's the most startling stat.
Hmm.
80% of the time, heart disease is preventable.
Hmm.
When we think about heart disease, it's about artery health. Arteries supply blood and oxygen to the brain, to the eyes, to the kidneys, to the livers, to the legs. If we stay heart healthy, I always say if we live from the heart and really protect those arteries, we're going to protect ourselves against dementia, Alzheimer's, heart disease, peripheral vascular disease, kidney disease. It is the essence of choosing how to live.
Mm.
Question becomes, how much do you care about yourself? How much are you going to love yourself to be responsible for taking care of your heart and living the life you choose?
I love that. I love that. And so tell us a little bit about Odessa.
Adesso, which is
Sorry.
Adesso. Odessa is a city. Anyway, fine. Odessa um, is Italian. And to me, that is like the romance language
Mm.
of love. And it means now. And here's why. I started on this journey 20 years ago when Go Red for Women through the American Heart Association started. I was out there for 20 years,
Mm.
running around the country, speaking about how to prevent heart disease in women. And I have been saying for 20 years, 1 in 3 women die of heart disease more than all cancers combined. Adesso means now. If the time is not now to
When?
change these statistics, when?
Hmm.
We've been doing this for too long.
Yeah.
When?
Yeah.
And so I have been running women in heart health programs in hospitals my entire career. And after doing this, I was like, you know what? I'm done. I am going to really do something that can have an impact on this statistic. and created Adesso. It's a technology platform really focused on primary care doctors because that's where most of
Yeah.
us go, and gynecologists, to implement diagnostic and treatment strategies that really focus on prevention of cardiovascular disease. And it partners with an app for women, My Adesso. It's in the Apple and Google stores. And it's the place to go. Let's go back to the beginning of this conversation for education, for empowerment, and for self advocacy. And lastly, it teaches you how to really live from the heart based on what your risk factors are, how you've lived your life, where those pain points are. Like you said, sit quietly. Think
Mhm.
about the times you were depressed, stressed. Talk to your family. Understand that history. And in Adesso, we ask you all those questions.
Mhm.
And it gives you an assessment. Are you low risk, moderate risk, high risk? And then it says, what are you going to do about it? Who are you? And what are you going to do about it? And
Yeah.
we give you the tools and the steps to do what you need to do to take care of your heart.
And I love how it's framed for women in the language that's very understandable and user friendly. It's really incredible. We'll make sure that we get the link out there as we share this as well to everybody. So, Dr. Suzanne, thank you so much for your time. This has been amazing, and just we so appreciate all the work you do. You've a pioneer, female phenom pioneer in this space, and we just appreciate where you've taken us so far.
Thank you so much for having me. And thank you for spreading the word. This is all about education, and it's great to be part of this. Appreciate you having me.